So good morning, everyone. Once again, so today's session will be about the breast, the mammary gland. Okay, also referred to as the mammary gland. Okay, so this will be your outcomes. So you'll be learning about the shape, the position, what are the gross anatomical and histological features, the blood supply, lymphatic drainage, and some of the clinical relevance. Okay, with reference to the mammary gland. Okay. First, we will see with reference the mammary gland. Okay, it's of more important, especially in females. Okay, because it has got a reproductive function as well for lactational purpose. Okay, so we will be talking about the mammary gland in a female. Okay, okay. So the mammary gland, it is roughly conical in shape. Okay, and it is present in the superficial fascia. There are different layers. So skin, the next one is the superficial fascia. So mammary gland, it's located in the superficial fascia. It has got a base, apex, and a tail. Okay, so because it's a conical shape, you know that it has got a base. The base is towards the pectoralis major. Okay, so pectoralis major, the muscles in the thorax. Okay, so majority is present in front of the pectoralis major muscle. Okay, as well as the serratus anterior muscle. Okay, and that's the base. The apex, it's by the nipple. Okay, and there will be a small extension of the breast tissue into the axilla, and this is referred to as the tail, also called as the axillary tail. Okay, it is also referred to as the axillary tail. The base, it extends from approximately, okay, it extends from the second rib until the sixth rib. Okay, superior inferiorly, it extends from second to the sixth rib, and from medial to lateral, it extends just lateral to the sternum. Okay, okay, just lateral to the sternum, the lateral border of the sternum. Okay, until the mid axillary line. Okay, until the mid axillary line. So you know that the anterior fold of the axilla, which is formed by the pectoralis major, and the posterior border is formed by latissimus dorsi. So in between these two folds of the axilla, you take an approximate midline. So that would be the mid axillary line. So this is the extension of the mammary gland. Okay, it has got no capsule. Okay, it has got no capsule, there is no deep fascia. Okay, so there is nothing which is covering up the mammary gland, there is no capsule. Okay, so why should we know about all these things? The first thing, whenever you are examining the breast, okay, examination of the breast, when you go into the clinics, there is a skill where you need to examine the mammary gland to find out if there are any lumps, okay, in the breast. So for which you need to know the extension of the breast. Okay, so that's why I told you the extensions. Okay, so even though it appears that there is no breast tissue in the second rib or in the mid axilla, you need to palpate and look for any breast tissue, any lump, okay, which is present in these areas. Okay, and don't forget to look into the axilla as well, because a small part of the axilla of the breast tissue extends into the axilla. Okay, small part of the breast tissue also extends into the axilla. Okay, and since it has got no capsule, it can spread. Okay, so whenever you read something anatomy, okay, don't stick on to only the anatomical aspects. think, why should I know about this? Okay, and look for the clinical relevance. Okay, so this will help you in solving your multiple choices as well as when you go into the clinics. Okay, as well as when you go into the clinics. Okay, roughly, the mammary gland can be divided into four quadrants, okay, by a vertical line and a horizontal line passing through the nipple, okay, into an upper quadrant, a lower quadrant, okay, into a medial quadrant and a lateral quadrant. So this quadrant, it will be, just a second, please. Yeah, yeah. So this quadrant is upper medial quadrant, okay, and this is upper lateral quadrant, superomedial, superolateral, okay, and this one is lower medial quadrant, lower lateral quadrant. So if you find a lump, you need to mention what is the size, shape, and in which quadrant of the breast you are able to find it. Okay, did you find the lump? So that's why you need to know about the quadrants. Okay, to know the exact location of the lump. Okay, and surrounding this nipple, the elevated area is called as the nipple, and surrounding this nipple there is a darkly pigmented structure which is referred to as the areola. Okay, which is referred to as the areola. Okay, the next one, in this picture, here you can see the mammary gland, which is present in the superficial fascia. And inside the mammary gland, you can see a large number of fat. Okay, so it's mostly by fat. Okay, you know, the superficial fascia is made up of fat. Okay, so it's mainly made up of fat. Okay, in a non-lactating female. Okay, in a non-lactating female, so it's mainly made up of fat. And the lactiferous ducts, they are present, they are rudimentary initially. Okay, once the female, she will get pregnant. Okay, so during the lactation period, so this will grow up, okay, and then start producing milk. Okay, and these are the lactiferous glands which comes out through the lactiferous ducts, and these ducts, they open into the nipple. Okay, now here if you see the lump, so this is, sorry, the breast mammary gland, and this is the pectoralis major muscle. Okay, so the pectoralis major muscle. Okay, so this is the mammary gland, this is the pectoralis major. In between this pectoralis major and the mammary gland, there is a small tiny space. Okay, you know that the pectoralis major is covered by a fascia. What fascia is it? Clavipectoral fascia. Okay, it is covered by the pectoral fascia or the clavipectoral fascia because it extends from the clavicle. Okay, and it covers the pectoralis major. So between this fascia, that's a deep fascia. Okay, pectoral fascia, clavipectoral fascia is a deep fascia. So between this fascia and the mammary gland, there is a space. Okay, a small space, and that is referred to as the retromammary space. Okay, the retromammary space. Okay, you can see a small white line, okay, which is extending here. So that is the retromammary space. Okay, so now why should I know about this retromammary space? Next question. What is the importance of it? Glands? Okay, I can't hear you. I will take it up later. The answers. Check out if it is correct. Because a lump in a breast can be benign as well as malignant. Please no talking. Okay, a lump in a breast can be a benign or malignant. You know the difference between benign and malignant, right? Okay, both are cancerous, but benign is less severe, whereas malignant, it spreads to the other parts of the body. Okay, a benign tumor usually remains within the mammary gland. Okay, whereas a malignant one, which is more dangerous. Okay, so even whenever you find a malignant, a lump, okay, which is malignant, how to say that this is a benign lump or a malignant lump? Okay, if there is an infiltration of this malignant lump, okay, it can invade the retromammary space. Okay, it can invade the retromammary space and it can get attached to the pectoralis major as well. So what happens whenever there is a lump, you need to see whether the lump is freely movable. Okay, a lump in a breast, if it is freely movable or if it is attached to the underlying structures. Okay, if it is attached to the underlying structures. So for which in your clinical skills, there will be various tests where they will find out whether the lump in the breast it's malignant or benign. Okay, so for example, how do you find out if the lump in a breast, okay, you are examining a lady, okay, and you are finding a lump, how do you say that whether this lump has infiltrated until the pectoralis major or not? How to say? Good. First thing is moving test. Okay, see if it is freely movable. Okay, the next one, but freely movable even when the person is normal also, even you just check the breast lump, it can be freely movable. The next one is you put the pectoralis major under contraction. Okay, when you put the pectoralis major under contraction, what happens? The pectoralis major contracts. If the lump, okay, if the lump is attached to the pectoralis major, the movement will be restricted. Okay, the lump will not move freely. Okay, the lump will not move freely. Okay, so when the pectoralis major, how to contract the pectoralis major? A simple test is ask the person to keep the hands over the hip and press the hip. Okay, you can see the pectoralis major is getting contracted. Okay, so ask the person to keep the hand over the hips and press. Okay, press against the hips. Okay, so if there is any infiltration, okay, the pectoralis major is contracted, the restriction, look before normally how does it move, and after the contraction of the pectoralis major, how the lump moves. If there is any restriction, it means that the lump has infiltrated the pectoralis fascia, the retromammary space, okay, and it is getting attached to the pectoralis major. Okay, the next question, why should I know about this infiltration? Because it influences your management, treatment. Okay, so if the cancer has infiltrated deep, not only removing the lump helps, you need to remove the pectoralis major as well, the fascia as well. Okay, so that is why this is important, the retromammary space, okay, and the underlying structures. How to contract the serratus anterior? Serratus anterior also forms a small portion. How to contract the serratus anterior? Push against the wall. Okay, ask the person, the patient to push against the wall. Okay, and then look for the lump. Any restriction in the movement of the lump. Okay, so that will tell you whether the please no talking. If you are not interested, please leave. Okay, so that will show whether the movement, okay, whether the lump is attached to the, it's infiltrating into the muscle. All right. So that's why we need to know about what is the base formed of, okay, and what is the importance of the retromammary space. All right. So each mammary gland is very important, not only in your first year, it will be following you until your final year. Okay, so they will ask you questions regarding this. Okay, and when your clinics, when you go, they will be concentrating more on the pathological aspects and treatment aspects. Okay, for which anatomy forms the basis. Okay, so this is why you need to know about the retromammary space and the structures which are underlying it. So here the arrow shows it extending from the second to the sixth rib. Okay, and here you can see it is underlying the pectoralis major. Okay, so the 2/3 of it lies over the pectoralis major, while the lower part, the inferolateral part, lies over the serratus anterior as well as external oblique muscle. What is this external oblique muscle? Where is it present? The external oblique muscle, it is a muscle in the anterior abdominal wall. Okay, it's a muscle, the first muscle of the anterior abdominal wall. After the skin and superficial fascia, there is a muscle. The abdomen also has got muscles, right? So the muscle in the anterior abdominal wall, which is the external oblique muscle. Okay, how to find out if how to contract the external oblique muscle? Ask the person to lie down and lift the head. Okay, that is flex the neck. Okay, ask the person to flex the neck, then the abdomen will be tight. Okay, the abdomen will be tight. The anterior abdominal wall muscles will contract. Okay, then you look for the movement. So that's actually, it is very large breasts. Okay, so if it extends, it can extend into the serratus anterior as well as the external oblique. Don't forget to look inside the axilla. Okay, so when you are palpating the breasts, okay, you need to palpate the axilla as well. Okay, so you need to, when you're looking for the lump, how to look for the lump? Usually with the pulp of your fingers. Okay, it is the pulp of the fingers. You need to check each quadrant. First check the one quadrant, the upper medial quadrant, then upper lateral. Okay, go in a cyclical motion from outside to in near the areola, or from inside to outside. Okay, go in a cyclical fashion, okay, to look for any lumps so that you don't miss a lump. Okay, you know that this is one of the most common cancers in female. Okay, so early detection will prevent morbidity as well as mortality. Okay, so that's why breast examination is very important. All right, don't forget to look into the superior lateral part, which is the axillary tail or axillary process. Any other name for it? Axillary tail of Spence. Okay, some books gave the full name Spence, Spence. Okay, axillary tail of Spence. Okay, that will be the full name for it. Okay, so here you can see the pectoralis major. Okay, so it is present over the pectoralis major, the serratus anterior as well. Okay, and you can see the breast tissue is extending into the axilla, deep into the axilla. Okay, so don't forget to look into the axilla for axillary tail, any malignancy of the breast tissue in the axillary tail. Okay, the nipple. The nipple, it's a conical eminence, okay, and it projects forward in the anterior surface, okay, of the breast. Approximately, it lies at the level of the fourth intercostal space, approximately. Okay, it differs from person to person. Okay, and what is present in the nipple? There are many ducts which open into the nipple, around 15 to 20 small ducts, the lactiferous ducts, they open into the nipple. Okay, usually they are rudimentary. So during the lactational period, they become active. Okay, during the lactational period, because of the secretion of the milk, sorry, they become active. Surrounding the nipple, the conical eminence, there is a darkly pigmented structure which is referred to as the areola. Okay, a pink brownish circular area, so which is referred to as the areola. The subcutaneous tissue, of the nipple and areola, they do not contain any fat. Okay, so if you dissect deep inside the nipple as well as the areola, you cannot find any fat. Okay, so deep inside it, there is mammary gland. It has got a large amount of fat, but in the areola and in the nipple, okay, so there is no subcutaneous fat. Okay, so as said earlier, it is a non-capsulated gland. Okay, so that's why a lump can spread onto any other part. Okay, and it is mainly composed of lobes and lobules. Okay, it's composed of lobes, okay, lobes and small parts with the lactiferous gland, so that is the lobules. Okay, and all these lobes and lobules, they are present in the subcutaneous fat of the superficial fascia. Okay, subcutaneous fat of the superficial fascia. Okay, now how does this fat, how is it kept in its position? Okay, so the mammary gland, it is present in the pectoral region, but how is it kept, how was these glands, they are kept in the pectoral region? Okay, so it is kept in the pectoral region by means of these ligaments, some fibrous strands. Okay, the fibrous strand which connect the skin with the deep fascia of the pectoralis major. There are some tiny glands, sorry, tiny ligaments which attaches the skin to the pectoralis major fascia. Okay, to the clavipectoral fascia. So there are some ligaments, some tiny ligaments which are present, which holds the mammary gland in its place. Okay, and that's why the mammary gland, it is present in the pectoral fascia. Okay, so otherwise it can be present anywhere. Okay, so it is kept in the, it is present in the pectoralis major, in the pectoral region, because of this ligaments, the ligaments of Cooper. Okay, the ligaments of Cooper. And as I said earlier, it is separated from the deep fascia. That is, what is the deep fascia here? It is the clavipectoral fascia. Okay, it is separated from the clavipectoral fascia by a loose areolar tissue or a space, which is called as retromammary space. Okay, the retromammary space. What is the importance? I already told you, for clinical applications. Okay, so if there is malignancy, if the retromammary space is involved, okay, we can understand that the lump has infiltrated, okay, and the lump is malignant. Okay, so even by your clinical examination, you can say whether the lump is benign or malignant. If there is an infiltration, it is most likely, okay, a malignant lump. Okay. And the retromammary space, it also allows the breast to move freely over the clavipectoral fascia. So here you can see some tiny ligaments here. So these are the ligaments of Cooper. Okay, so these are the ligaments of Cooper. Okay, now another thing, another important clinical relevance with regard to the ligaments of Cooper. So what is the other one? Suppose if it is a malignant tumor, okay, a malignant cancer of the breast, okay, the malignant cancer can infiltrate, as you know that it can infiltrate. It can infiltrate the ligaments of Cooper. Okay, it can infiltrate these small tiny ligaments which hold the mammary gland in its place. Okay, and what happens if it infiltrates these ligaments of Cooper? If it infiltrates the ligaments of Cooper, the ligaments of Cooper will contract. Okay, it will contract. And what happens when it contracts? What happens when these ligaments contract? There will be puckering of the skin. Okay, puckering. That is, the mammary gland will look abnormal. Okay, so there will be some depression. There will be the pulling of the mammary gland on both the sides. Usually it's not similar, but there will be puckering, means like something which pulls it from inside. Okay, something which pulls it from inside. So on your inspection, in your clinical skills, there is inspection, palpation, percussion, auscultation, right? So on the inspection of the mammary gland, before you proceed on to the palpation, during the inspection, you need to look for any puckering of the skin. Okay, I will show you. There are pictures. I will show you how does a puckering of a skin look like. Okay, so this puckering of the skin, that is, the skin will be pulled inside. Okay, the skin, because of the involvement of the ligaments of Cooper. Okay, and if there is any puckering of the skin, you need not even examine. It means that there is a lump, and it is most likely it is a malignant one. So even before you go for a palpation, you can say that this is a malignant tumor. Okay, so that's the relevance, clinical relevance of ligaments of Cooper. Okay, the ligament of Cooper. Okay. Okay, so as I said before, it is formed around 15 to 20 lobes. Okay, so the lobes, and each lobe has got a lobules, small tiny lobules. Okay, and they are separated from each lobe and lobules. They are separated from one another by fibrous tissue. Okay, which is called as the ligaments of Cooper. The ligaments of Cooper. I already told you the importance of it. These ligaments give the breast support by connecting the skin to the pectoral fascia. Okay, to the pectoralis fascia. Okay, and from the small lobules, okay, the milk will be produced in a lactating female. The milk will be produced, and then they come out through the lactiferous ducts, okay, which open into the areola. Okay, which opens into the it opens into the nipple, not the areola. I'm sorry. It opens into the nipple. Okay, the lactiferous ducts, they will all join together, and then they will open into the nipple. Okay, so in this picture, you are able to see the ligaments, the suspensory ligaments of Cooper. Okay, the superficial fascia fat, the lobes, and the lobules. Okay, this tiny ones are the lobules, and this entire one is a lobe. Okay, and the lactiferous ducts. Okay, the nipple and the areola. Apart from this, if you look into one of this lactiferous duct, okay, concentrate on the lactiferous duct. The lactiferous duct, as it comes towards the areola, okay, there is a small dilatation. Okay, there is a small dilatation, and this dilatation is referred to as the lactiferous sinus. Okay, a small dilatation of the lactiferous duct, which is underneath the areola. It's referred to as the lactiferous sinus. Okay, it's referred to as the lactiferous sinus. Okay, now what is the importance? Whenever you read something, look for what is the importance of it. Okay, then it becomes interesting. Okay, the lactiferous sinus. So this is the place. The milk will be constantly produced by the mother. Okay, and it will be present in the lactiferous sinus. Okay, and when the baby is sucking the nipple, okay, so when that is, which is called as latching. Okay, latching the baby to the breast. Okay, so usually there will be a common complaint that the baby is not having enough milk. The mothers will complain that the baby is not having enough milk or the milk is not sufficient. Okay, that is usually because they will not know how to latch the baby. Okay, so how does this occur? So whenever latching the baby, okay, whenever the baby is made to feed, whenever the mother is feeding the baby, they need to make sure that the entire areola is being taken by the infant, by the baby. Okay, not only the nipple. Okay, if the baby starts sucking only the nipple, okay, the milk will not come. Because why? When the baby is sucking only at the nipple, only the lactiferous ducts. Okay, so they will have their they will suck only from the nipple. Okay, there won't be any sucking reflex. Okay, the sucking will not be proper. So whenever the mother is feeding the baby, the you need to teach the mother, okay, how to feed the baby. That is, they need to take a small portion of the areola as well, okay, before feeding the baby. So that what happens when the areola also goes inside the baby's mouth, the lactiferous sinus is also going inside. Okay, and as the baby develops the sucking reflex, the milk starts flowing down, which is called as the suckling reflex. Okay, the suckling reflex. Because of this reflex action, more milk will be produced. Okay, so this is a very important one, the lactiferous sinus, especially in your clinics. They will be in your pediatric postings, so there will be a common complaint. Okay, so there will be, so you need to, there are some special consultants as well, the nurses, midwives, so they will be teaching how to feed the baby. Okay, so what is the anatomical relevance? You might need to explain it to the mother. Okay, so the lactiferous sinus. Any doubts until now? Okay. The next one is regarding the blood supply. Okay, the blood supply of the mammary gland. Okay, so this is with relevance to the surgery, right? So whenever you're going to do the surgery, the removal of the cancer, which is called as mastectomy, the removal of the breast, which is called as mastectomy. Okay, so what happens? You need to make sure that there is no bleeding. Okay, so not much of bleeding. So what are the arteries which you are going to encounter? So these are the internal thoracic artery. Okay, the internal thoracic artery. So here you can see the internal thoracic artery. The internal thoracic artery is a branch from, can you see what is this artery? It's a branch from subclavian artery. Okay, so branch from the subclavian artery, which is the internal thoracic artery or the internal mammary artery. Okay, and on the lateral side, it is by the lateral thoracic artery, which is also from the third part of the subclavian artery. So the lateral thoracic artery. Okay, and small branches from the intercostal arteries. Okay, small branches from the intercostal arteries. Okay, so these are the different branches. Those who leave the class, please don't come back again. You need to ask permission. There is a person who is talking over here. Please don't come back again. You can leave the class. Okay, so internal thoracic artery, lateral thoracic artery, and intercostal arteries. Okay, so these are the three major blood supply to the mammary gland. The venous drainage. The venous drainage, they correspond to the arteries. Okay, there are circular venous plexus around the base of the nipple, and then they finally drain into the axillary, and the internal thoracic veins or the internal mammary veins. Same. Okay. There will be small venous plexus around the mammary gland. Okay. And then they drain into the axillary vein as well as into the internal thoracic veins. All right. So the arteries and venous drainage are more or less similar. Okay. Coming to the lymphatic drainage, once again, you know the importance of it. Okay, any malignancy is usually the malignant cells can be present in the lymph nodes. Okay, so that's why you need to know regarding the lymphatic drainage of the breast. So most of the lymphatic drainage from the breast, they go into the axillary group of lymph nodes. Okay, into the axillary group of lymph nodes. Already the class on axilla has been over, right? Did they cover the lymph nodes? Yes. Okay, so I'm not going into the detail, but I'll just give you an overview. The last bench. Please sit separate. Yes. Okay, so there are many groups of axillary lymph nodes. So usually they are grouped into 5. You know the shape of the axilla. What is the shape of the axilla? Pyramidal shape. Okay, so it has got a base, okay, an anterior fold, a posterior fold, medial, lateral, apex. Okay, so each fold has got a group of lymph nodes. Okay, so just behind the pectoralis major, so that's called as pectoral group of lymph nodes. Okay, the pectoral group of lymph nodes. So they lie along the lateral thoracic vessels, pectoral group of lymph nodes. Then on the posterior part, okay, the posterior part, it is the subscapular group of lymph nodes, the subscapular group of lymph nodes, okay. So they lie along the subscapular vessels. Excuse me. Next time you leave, ask permission. If not, you can leave the class. Subscapular group of lymph nodes, which is lying along the posterior wall of the axilla. The lateral group of lymph nodes, which is lying along the arm. Okay, so that forms the lateral group of lymph nodes. They lie along the axillary artery. Okay, the axillary artery and vein. So that is called as lateral group of lymph nodes. The medial group of lymph nodes is usually along the ribs. It's not mentioned here. Okay, it is usually present along the ribs. So that's the medial group of lymph nodes. The central group of lymph nodes. So this is the central group of lymph nodes, which is present exactly near just up the floor of the axilla. So that will be the central group of lymph nodes, which is usually embedded in the axillary fat, and the apical, which lies quite deep. If you put your hands deep inside the axilla, okay, so that will be the apical group of lymph nodes. Okay. Remember, examination of the breast is not complete without looking for the lymph nodes. Okay, sometimes you might not feel the lump, but there could be a lymph node enlargement. Okay, if you find a lymph node enlargement, okay, look for the any breast lump, okay, and do a biopsy immediately. Okay, especially in a female if you are suspecting a cancer, malignant cancer. Okay, so to rule out cancer breasts. Okay, because early detection is very important. Okay, so these are the groups of axillary group of lymph nodes. Pectoral or anterior, pectoral or anterior group, posterior or subscapular group, lateral or brachial group, central group, apical group, and a medial group which is not mentioned. Okay, all this it goes into the subclavian lymphatic trunk. Subclavian lymphatic trunk, and on the right side it opens into the subclavian vein, and on the left side it opens into the thoracic duct. Okay, right side it drains into the subclavian vein, the right subclavian vein. Okay, and on the left side it goes into the thoracic duct. Okay, and that's why if the malignant cells escape into this systemic circulation, the malignancy could become systematic. Okay, so it could become systemic. Okay, so it can affect any organ. That's why the metastasis can be found in any parts of the body. Okay, once it enters into the circulation. Okay, so the lymphatic drainage with relevance to the breast. Okay, so they lie around the behind the areola, that is the subareolar lymphatic plexus, and the deep lymphatic plexus. They drain into the deep fascia, lies deep fascia over the pectoralis major. Okay, deep fascia covering the pectoralis major. Both these plexus radiate in many directions. Okay, they radiate. Okay, they radiate in all directions into different lymph nodes. Okay, they can go into any one of the lymph nodes. Now I was discussing only about the axillary group of lymph nodes. Are there any other group of lymph nodes? Yes, there are other groups of lymph nodes which the breast tissue can drain into. It can drain into this chain of lymph nodes which is present immediately behind the sternum. So that's called as internal thoracic lymph nodes. Okay, the internal thoracic lymph nodes. Okay, it can also drain into the internal thoracic lymph nodes. So here you can see the different groups by which the breast lymphatics drain into. Okay, so here you can see usually from the lateral part of the mammary gland, it goes into the pectoral group of lymph nodes. Okay, finally draining into the apical group of lymph nodes. Okay, and the medial side, okay, it can go into the internal thoracic group of lymph nodes. Okay, the inferior aspect can go into the abdominal. Okay, that can go into the lymphatics inside the abdomen. Okay, can go into the subdiaphragmatic lymphatics. Okay, so the mammary gland lymphatic drainage is very important. Okay, both for anatomical aspects as well as for your clinical relevance. Also, if you note, the lymphatics, if the malignancy from one breast, okay, it goes to the lymphatics, it can spread from one side to the other side. Okay, you can see here anastomosis with lymphatics of the opposite breast. Okay, so if you find a lymph node, okay, or a cancer in one side of the breast, okay, don't forget to examine the other half. Okay, because the malignant cells can spread through the lymphatics to the other side breast as well as the other side lymphatics as well. Okay, so that's very important. And also once it enters into the abdomen, it can spread to anywhere, peritoneal metastasis. And there is a tumor of the ovary, okay, which is related to the breast. The malignant cells from the breast, once they enter into the abdomen, okay, so these malignant cells can go and get attached to the ovary, and they can turn the ovary into a malignant ovary, okay, which is called a Krukenberg tumor. Okay, in your pathology, you will be learning about it. Okay, Krukenberg's tumor. So where the tumor can spread to the ovary as well. Okay, so the lymphatic drainage is very important. Okay, and here you can see most of the drainage from the breast, it goes around 75%, it goes into the axillary group of lymph nodes. Okay, into the axillary group of lymph nodes, usually the pectoral, and from the pectoral to the apical group of lymph nodes. The medial aspects go into the internal thoracic, along the internal thoracic veins and artery. the internal thoracic lymph nodes, okay, or it's also called as parasternal lymph nodes because they are parallel to the sternum, parasternal group of lymph nodes. Okay, some lymphatics from the medial part can go to the opposite side. Okay, can go to the opposite side and affect the opposite side breast as well as the lymphatics. The inframedial part, it can enter into the abdomen, okay, through the subdiaphragmatic lymphatics. All right, so this is with regard to the lymphatic drainage. Now regarding the clinical relevance, I have already told you the relevance then and there. Okay, so we will just revisit it again. So cancer breast, you know that it is very common surgical conditions. Okay, and 60% of the cancer, they are usually in the upper lateral quadrant. Okay, and you know that it can involve the axillary group of lymph nodes. Okay, examine the other breast because the axillary lymph nodes on the other sides can also be, because the lymphatic drainage can go to the other side breast as well. Okay, what happens in case if there is a cancer? What is the surgery? Mastectomy. It's called as mastectomy. What is simple mastectomy? Simple mastectomy is removing only the breast tissue. Okay, removing the lump as well as the breast tissue. That's called a simple mastectomy. Okay, and there are many varieties of complete mastectomy is also there. In complete mastectomy, they will remove the pectoralis major, minor, everything. Okay, so depending upon the infiltration. Okay, so they might remove the other ones, the structures which are involved as well. Okay, so that is complete mastectomy, and they will be followed by radiotherapy, chemotherapy. Okay, whichever the treatment of the choice. And along with this mastectomy, the corresponding lymph nodes should also be removed. Okay, I'm not going into the details of the surgical aspects. Okay, the name of the surgery. Okay, so those things will be taught to you in your final years. All right. So the name of the surgery is mastectomy. Okay. All right. The lactiferous duct, sorry, the lactiferous ducts, they are arranged radial fashion. Okay, you know that they are present in radial fashion. So if you are going to make an incision, so sometimes there could be an abscess. Sometimes there could be a breast abscess. Okay, an abscess, which is an infection of the lactiferous glands. Okay, what happens in case if there is an infection? Okay, why there is an infection? So probably because of improper latching, okay, improper feeding, where the infant tends to bite the nipple and then there will be cracks in the nipple. Okay, so through which the infection can enter and it can infect the breast, leading on to mastitis, okay, and as well as abscess. Okay, so in case if there is an abscess, you need to do an incision and drainage. Okay, so where you need to make an incision. When you are making an incision, you need to make a radial incision in case of abscess. Okay, why a radial incision? Why not a horizontal or vertical one? Because when you are going to make an horizontal or a vertical incision, you are going to cut through the lactiferous ducts. Okay, when you are going to make a vertical or horizontal, you are going to cut through the lactiferous duct. And whenever you cut it, after healing, there could be fibrosis. Okay, as a result, because of the fibrosis, once again, the milk will not come up. Once again, the abscess will recur. So usually the incisions are placed in a radial fashion. Okay, in case of abscess. This one I already told you. Okay, the infiltration of the ligaments of Cooper. So what happens if the ligaments of Cooper are involved? The skin over the mammary gland is changed. Okay, so here you can see there are small puckering of the skins. Can you see? Because the lymphatics are involved, there is subcutaneous, there is the lymphatics are involved, the lymphatic drainage is not proper. Okay, and there is infiltration of this ligaments of Cooper. So this ligaments of Cooper will pull the breast. So it looks like an orange skin appearance. Okay, so this is a French further orange appearance, which means that it looks like an orange peel appearance. The skin of an orange. Okay, so in a normal mammary gland, you will not be able to see these small tiny puckerings. Okay, in case if you find during the inspection of a mammary gland, okay, this orange peel appearance or pure the orange appearance, suspect cancer. Okay, suspect cancer and ask the person to do investigations like mammogram. Okay, and in case if you find a lump, do an FNAC. Okay, biopsy. All right, the next one, mammary ridge. Mammary ridge, this I will be discussing it in the embryology as well. Okay, so mammary ridge. This is a ridge which extends from the axilla to the inguinal region. This is called as the mammary ridge. Okay, why this is important? The breast can form at any place along this mammary ridge. Okay, right from the axilla to the inguinal region. Okay, you can see some animals, they are having multiple nipples. Okay, several mammary glands are formed. Example, dogs. Okay, so there it can be found along the entire mammary ridge. Okay, but in humans, okay, because of the genetic, okay, the messenger codes, okay, the mammary gland develops only in the pectoral region. Okay, it develops only in the pectoral region. The other part of the mammary ridge disappears in human. Okay, so what is this? Is it a normal breast or an abnormal breast? Normal or abnormal? Yes. What are the abnormalities you note in this breast? Yes, one is the orange peel appearance. So that's because the lymphatics, they are not drained properly. Okay, so as a result, there is a lymphatic accumulation. Okay, there is a lymphatic accumulation as well as the ligaments of Cooper is involved. Okay, that's why the orange peel appearance is there. Okay, any other? Good, very good. You can see the puckering of the skin around the areola, okay, and the nipple, an inverted nipple. Nipple is usually everted, so in this case, the nipple is retracted. Okay, so you need to have the inspection correct, okay, before you proceed on with the palpation. Okay, so you can see the orange peel appearance, okay, the puckering of the skin around the areola, okay, as well as the inverted nipple, okay, which all can suggest that this person could have a malignant cancer of the breast. Yes, what is this? Normal or abnormal? If abnormal, what is the abnormality? Good. Accessory nipples, or you can call it supernumerary nipples. Okay, accessory nipples or supernumerary nipples. And another thing, if you note it, it is along the mammary ridge. If you see these accessory nipples, they are along the mammary ridge. You know what is a mammary ridge? Extending from axilla to the inguinal region. Okay, so that's the mammary ridge. Of course, it's written here. What is this? Montgomery tubercles. You can see the nipple, the areola, the border at the edges of this, the areola, you can see some small dilatations. Okay, these dilatations are called as Montgomery tubercles. Okay, Montgomery tubercles. Excuse me, next time you leave, you need to ask permission, right? So Montgomery tubercles. So these are present along the lateral border, okay, surrounding the areola. What do they signify? These are nothing but the sebaceous glands or rudimentary lactiferous ducts, okay, and usually they are found in pregnant females. Okay, in pregnant and lactating females, they are more prominent. It is also one of the signs for pregnancy. Okay, Montgomery tubercle. Okay, small dilatations, which are, it's a physiological change of the mammary gland. There is nothing pathological about it. Okay, Montgomery tubercles present usually in pregnant and lactating females. Normal or abnormal? Normal or abnormal? So in this case, it is abnormal. For the next thing, is it a male or a female? So what do you call this condition? Gynecomastia. Okay, gynecomastia. Okay, usually the mammary gland in males, they are rudimentary, non-functional. Okay, but sometimes it can get enlarged. Okay, either because of certain drugs, usually the cause could be drugs, obesity, okay, or it could be because of some tumors that can secrete estrogen, testicular tumors, okay, so or because of low testosterone levels, so that's why that could be. So there will be an enlargement of the breasts in males, so that's called as gynecomastia. Okay, usually if you treat the underlying cause, this will disappear. Okay, and sometimes if it is an estrogen secreting tumor, there could be something like a white discharge can also be seen. Okay, all right, these are some of the abnormalities: polythelia, athelia, polymastia, amastia, and amasia. What are these ones? Polythelia. Thelia means nipple, supernumerary nipples. Okay, so the other name is polythelia. Okay, polythelia. If there are no nipples, it's called as athelia. No nipple, it's called as athelia. More than one breast, accessory breasts, polymastia. If there are no breasts, amastia. If there are no nipple, no breasts, amasia. Okay, so different terminologies for each one of them. Okay, polythelia, athelia. Poly means many, and a means it's absent. Okay, already it's been mentioned. Poland syndrome. What is the abnormality you see here? Good. Okay, Poland syndrome. Pectoralis major. The congenital absence of pectoralis major. Okay, the congenital absence of pectoralis major on one side. Okay, you can see the thorax. Okay, on this side appears to be normal. On the other side, it's abnormal. Okay, so this is how it looks in case of sometimes the complete mastectomy. If they remove the pectoralis major, it can look like this, and that can cause disfigurement. Okay, and can also have a a psychological impact on the patients. Okay, so that's why early detection of cancer breast is very important. I have given you as this for your self-learning. Okay, try to find out what are these structures. Okay, try to find out what are these structures. So during your free time, you can have a look into this picture and try to decode it. Okay, now just I will take you another 10 minutes. Okay, not more than 10 minutes. So we will finish off the embryology and the histological aspects. Most of it is already completed. Okay, just a few points. So you know that the mammary glands, they are modified apocrine type of glands. Okay, they are modified apocrine type of glands. Okay, and they connect ducts and connective tissue stroma. Okay, the mammary buds, they usually develop in the 6th week. Okay, as a downgrowth. I will show you from this picture. So here you can see around the 6th week along the mammary ridge. Okay, so there will be the epithelial proliferation. It goes down. Okay, and then they form the lactiferous ducts. Okay, usually it remains rudimentary. Okay, and during the puberty there will be the development of the mammary gland. Okay, so because of the FSH and LH. Okay, what is FSH? Follicle stimulating hormone, luteinizing hormone, estrogens. Okay, progesterone. So those hormones, they will be helping in development of the breast in females. Okay, so here also just the same thing I have explained it here. Okay. So initially you can see there will be a small elevation, then the nipple is formed, and through the nipple the lactiferous ducts, okay, then the lobules, they will be formed. Okay, now postnatally, what is this witch's milk? Sometimes you can see the newborn, be it male or female, okay, there will be some small milk secretion from the breast of the baby. Okay, be it a male baby or a female baby. This is called as witch's milk. Okay, so what is the reason behind it? So usually it is because of the maternal hormones. Okay, the maternal hormones, they can cross through the placenta, okay, and they will lead on to the development of the breast in the newborns. Okay, but after birth, because the maternal, it is cut off from the maternal circulations. Okay, so there is no longer the hormones, the breast will regress by itself. Okay, so this is called as witch's milk. It's a normal phenomenon. Okay, but some parents might be anxious about it. Okay, you need to explain them that it will come down. It's because of the hormones which are coming from the mother to the babies. So this is one which I already told you. At around the puberty, the breasts enlarge. Okay, and during the pregnant times, because of the pregnancy hormones, okay, like what is the pregnant HP? What is the pregnancy hormone? Human HCH. What is it? Human chorionic gonadotropin, human placental lactogens. Okay, so there are many hormones. Okay, so the breast develops much more. The lactiferous ducts and the lobules, okay, so they become proliferated. And then after birth, because of the secretion of the oxytocin, there will be ejection of milk. Okay, the lactiferous ducts, however, in case of male, they remain rudimentary. Okay, unless until there is any pathological condition. The postnatal development of females in female breast. So usually in the newborn, there is not much changes. Around the puberty, there are several changes in the breasts. Okay, so these are called as Tanner's stages of development. Okay, so sometimes mothers they come with a complaint that the girl child has not attained menarche, that is the periods. Okay, so which is called as primary amenorrhea. Primary means first, amenorrhea no menstrual periods. So in those cases, you need to look for what is the cause. Okay, so you need to look at the secondary sexual character developments. So the secondary sexual character developments, which include the hair development in the axilla over the genital regions. Okay, so that's the secondary sexual character, as well as the development of the breast. Okay, so these are different stages in the development of the female, okay, during the postnatal period, which can help to diagnose whether the child is having a primary amenorrhea due to a cause which is lying in the pituitary or in the ovary, or it is just a delayed onset of menarche. Okay, some children they might have a delayed onset of menarche. Okay, so you need to look into that secondary sexual characters as well. So these are the different stages. So initially you can see there is a version of nipple, then there is a small deposition of fat over the pectoral region, then this fat gets enlarged. Okay, so these are the different stages, Tanner stage in the development, which you will learn once again in your pediatric postings. This already we have dealt with, gynecomastia, as I said before, because of the decreased ratio between the testosterone and the estradiol, and it's also seen in Klinefelter syndrome. Okay, you must have read in the hematology immunology module, right? Klinefelter's 47 chromosomes, right? And extra X. So Klinefelter syndrome. Athelia amastia, which has already been discussed. Okay, so Poland syndrome. So where there is congenital absence of pectoralis major. Okay, inverted. Sometimes inverted nipple can be congenital also. Okay, can be congenital also. And what is the problem with such kind of mothers? So the mothers, when they are feeding, if it is an inverted nipple, then they will have difficulty in latching with the baby. Okay, so the baby cannot have sufficient milk. Okay, so there are techniques which you need to teach the mother how to feed the baby in case if there is an inverted nipples, which is beyond the scope now. Okay, lastly, the histology of the mammary gland. So as you know, these are modified apocrine glands. Okay, they are separated into lobes and lobules. There is a lactiferous duct, lactiferous sinus is also told. Okay, the areola, tubercles of Montgomery. I have just repeated the same thing so that you can understand better and to concentrate on which points. So once again, the gross features of the breast. Okay, coming to the histological features. It is composed of parenchyma and stroma. The parenchyma contains the glands, which are tubuloalveolar glands, and these are lined by cuboidal epithelium. The cuboidal epithelium is surrounded by the myoepithelial cells. What is the meaning of myo? Muscles. So around this gland, there are some tiny muscles which are also present. Okay, and stroma. Stroma is the fatty tissue which is present, which is the connective and the adipose tissue. which is present. Okay, so here you can see this is the lactiferous, the gland, okay, which contains the milk, and this is the stroma, the connective tissue. Okay, so here you can see the gland. This is a duct which is composed of stratified stratified cuboidal epithelium. Okay, stratified cuboidal epithelium. So this is how we differentiate between a lactating breast and a non-lactating breast histologically. Okay, so here you can see this is a lactating breast histology and this is a non-lactating. What is the difference? Here the glandular development is more, here the glandular development is less. Here the stroma is less, here the stroma is more. Okay, so glandular tissue in a lactating it is more, in a non-lactating it is less. The alveoli or the glands, they are well developed, here it is not developed. The branching pattern of glands extensive, here it is not much extensive, only the ducts can be seen. The intralobular duct, both are same. The duct lumen, here it is filled with milk because it's lactating, here no milk. The connective and adipose tissues, that is the stroma, it is less, it is more, the fatty tissue is more in non-lactating, whereas in a lactating it is less. The intralobular connective tissues, they contain less, they are less and they contain lymphocytes and plasma cells. Here it mostly contains the fibroblasts. Okay, this myoepithelial cells. Myoepithelial cells, how do you know that they are existing? Sometimes the mothers, they start secreting the milk when the baby cries. Even before the baby is latched into mother's breast, even before the baby starts feeding, okay, if the baby cries, automatically the milk will start to flow. Okay, so that's all hormonal related. So because the brain's response, it starts hearing and then the oxytocin starts producing, and once because of the oxytocin, this myoepithelial cells, they contract and then the milk starts flowing down even before the mothers start feeding the baby. Okay, so that's the importance, the clinical relevance, and this is how you differentiate between a mammary gland, a lactating mammary gland and a non-lactating mammary gland. Usually in the histology here, we are having a lactating mammary gland. Okay, but this might also be kept, okay, in your OSPE exams. Okay, so in this slide, I have just coded out each one for your reference. Okay, don't expect the same slide. Okay, so this is for your relevance. Okay, for your reading. Okay, so here you can see the lobule. So this entire thing is a lobule. The interlobular duct, the intralobular duct. Okay, the connective tissues and the interlobular connective tissue. In a lactating, you can see more glandular tissues. Okay, the same thing, the secretory unit, and this will be the interlobular duct. Okay. This is also another slide of the lactating mammary gland showing the milk secretions. What is this? Corpora amylacea. Corpora amylacea. Suppose if the milk stays inside the lactiferous, inside the mammary gland for a long time, okay, so they can have this appearance. Okay, so this is called as corpora amylacea. The secretions of the milk which is staying inside the breast for over a period of time. Okay, so that's called as corpora amylacea. All right. So breast cancer, we have already dealt enough about this. The milk ejection reflex, so which is concerned with regard to oxytocin. I was telling you, right? What happens when the baby cries? So because the baby cries, okay, so the brain it stimulates, and then the oxytocin they start secreting, okay, and the milk flows freely because of the presence of myoepithelial cells. All right. Any doubts? If you still have any doubts, please do let me know. Email me